So if you are not familiar, this is Dr. John Burton. He, I would say, is effectively, and you'll probably roll your eyes at me, but one of the fathers of geriatrics, and was a geriatrician before it was really even a field, or he was at the beginning of the field of geriatrics, kind of paving the way. And Jane is a phenomenal geriatric nurse and is an expert on geriatric medicine, primary care, and also the resources we have in our community for our aging patients. And she and Dr. Burton have worked together for decades and have a collaboration that's second to none and pretty impressive.
So I went to Dr. Zeeb, the chairman of medicine at the time, and I said, you know, it's great here, I love it, but I think I need to do general medicine. He said, are you sure? I said, I think I've got to try it. And instead of saying, well, that's fine, why don't you go into private practice? He said, it's not a bad idea, frankly. We don't have anything like that. Why don't you start a clinic down on Eastern Avenue? So we opened a community office. It's now an all-state insurance company on Eastern Avenue. And patients began to come. It turned out to be absolutely fascinating. And 4 or 5 or 6 years into that operation, it was booming, house staff were rotating down, it was fun. And Dr. Zeeb called me back to the office and said, well, that's going pretty well. Why don't you think about this? Move that practice back to the campus. So I said to Dr. Zeeb, well, you know, I don't know anything about geriatrics. He said, well, you know, I know, but nobody does. Well, look, you have to look at the demographics. Almost half the patients in hospitals are older, and it's going to get more and more, so we better begin to learn about that. That's how I got into geriatrics. I came from the primary care base. I believe strongly in the primary care base. And shortly after we moved the practice back here, met Jane Marks, who had come to work on a research project with a colleague we had recruited, and got the idea that maybe a partnership with a doc and a nurse would be better than either of us alone. I can't imagine a more engaging, rich professional career than we've had. I am clearly in a much better position because of Jane's influence. And together we engage the community and our patients. And I would say most of our patients, they really want to talk to Jane more than me. So Jane, why don't you explain the story? And I think it's probably 33 years or so we've been practicing together.
So 33 years. So I came when I finished graduate school back in the 80s. University of Maryland actually had one of the first geriatric nursing programs in graduate studies. And I had noticed from the acute hospital I worked at that a lot of my patients were older, and there wasn't really a lot known or regarding staffing and needs, so that was my interest sparked. And when I finished graduate school, I thought, well, I'll come over here and interview. Not sure I'd really take a job here, but the day I interviewed, I met such fascinating people and doing such exciting things that I was excited to start. So I came from a background where actually I worked in community health for part of my experience, and I was allowed to be on the street, so I loved that. And then one day when I was working with Dr. Burton, we had a patient who came in who was quite ill, and I'll have to show you the picture. So he needed to go to the emergency room and wouldn't go because he had a truck full on the back of his station wagon full of crabs. And so Dr. Burton looked at me and said, do you think you can drive that big old station wagon? Pick up his wife after you take him to the emergency room. And after that, I knew I was going to love working with them. And that was like within the first couple months, I think. So that kind of started my, as I say, my adventures out in the community. I got to know the community quite well, I think. And this patient and his wife became like family, I think, over the years. They lived here close to the hospital, and we were always in contact. But I think, too, it showed that outreach that we do, that special need. And, you know, certainly working with them was an honor, and they taught me many things about, I think, just understanding individual needs as well as compassion and those sorts of things. So it's Dr. Burton and I feel like we had a lot of support. Home care was always engaged with a lot of our patients, so certainly working with them to help support things. I just want to point out the blonde in the back. She's actually a nursing assistant. When her car broke down, she rode her bike to visit patients because she didn't want to have someone else see them. So, I mean, the dedication of them too is part of our team, and that's why I feel like it really was. Our staff in the clinic that we had in the Beecham Center was remarkable. They were just so dedicated. They knew if someone called and they were a little confused that this was an issue, because they normally weren't like that. They would pick up on tips. So I think too, the team effort, like you have teams in the primary care practice that you see, having those MAs know your patients, I think all of that adds to what we all do in work, because they certainly can be a valuable input. And then the other thing we didn't talk about is just community was neighbors. I mean, how many of you have neighbors that bring your patients and really provide care, unpaid care? That's unbelievable. And engaging them and helping and educating, I think, too, has been a real asset that I've seen over the years.
We, in the 60s and 70s, had to depend on our instincts, our physical examination. The danger now is that you've got so much that you don't have to depend on your history taking. We labored over that history because our decision was, we're going to take this person to the operating room and explore their belly or not. You really wanted to have the history right. You really wanted that examination right. Now, so the trap that you're in is forgetting those skills that make you a great physician. For example, the ability to listen, really listen, really understand, really connect with that person, really connect with that family. And then examine them thoroughly and believe in your results. You get that through practice, you get that through habit. Excellence is all about habit. So it's easy to lose those skills and depend on all of the gizmos and imagery. But I think if you can couple the two things together, the best of old-fashioned medicine, history, physical, knowing your patient, exam, and then ask the question, what is the right image here? How do you cut that thing off? So I think now in the days of precision medicine, where in 10 years they're going to get a gene array and say, here's the drug you want to use for this particular, that's great. I think it's truly great. But use the technology to your advantage. Don't let it drive you. You ask the question of the technology. And always remember the human being. Because medicine has gotten so complicated and so expensive that it's no longer affordable. A lot of the cost of healthcare is driven by physicians. And there is unequivocal evidence that high-quality primary care decreases the overall cost of care while increasing quality. I think the most exciting days of primary care are in the next decade or two.